afternoon, Prynhawn Da. My name is Caroline Phipps and I'm the Chief Exec of Barod, and I'll be chairing this webinar today. This is the 8th of a series of 10 webinars about our manifesto. So Barod's manifesto sets out a blueprint for a more equal and prosperous Wales for people who use substances. We believe we can all do better to meet the needs of people who use substances, their families, loved ones, and communities. We really do need to drive forward innovation in policy and practice that will help reduce harm and save lives of our fellow citizens. We also believe we need to hold Welsh Government and Westminster to account and demand that we have a vision for Wales and a strategy developed with our services and with people with lived and living experience. So you can find our manifesto on our website, along with more detailed policy papers on each of the 10 asks, both in English and in Welsh. So today's webinar will focus on community drug checking services. We want community drug checking services to be part and parcel of harm reduction interventions across Wales. These services allow people to get their substances tested without fear of arrest and find out what is in the substance, receive tailored harm reduction advice and some brief interventions if needed. The need for drug checking services is as significant as it ever was, given the threats posed by dangerous toxic substances, most notably synthetic opioids. It just makes sense. So to tell us how we can get these services in place and the benefits they bring, we have two great speakers for you this afternoon. So first up, our very own Gavin Jones, Head of Operations for Gwent Drug and Alcohol Service, GDAS. So over to you, Gavin.
Okay, so like Caroline said, I'm Gavin Jones. I'm the Head of Operations for GDAS. A lot of you will know me because I bounced around between Barod and Kaleidoscope across South Wales for the past 20 years or so. I'm also a harm reduction lead for Kaleidoscope. I haven't put my email on there, but we can provide that with the slides if anybody wants to contact me later. So first, I just wanted to touch a bit on that Caroline was talking about the synthetic age. So we have seen synthetic opioids with fentanyl in North America, nitazines in the UK. We are seeing more and more through Wedinos the amount of counterfeit diazepam and Xanax, and there's an example there of people selling them for £1 each. And then I've also got a picture of a bag of allegedly 300 milligram pregabalin that was sold for £150. And more recently, we're seeing counterfeit vodka laced with isopropyl alcohol that was available in Newport for £10 a bottle. So I think the reasons are there about the synthetics, and I was talking yesterday to Katy and I realised how far back it actually reached, where the idea actually came from. And I think around December 2023, I was having discussions with friends that worked in the service, and we were seeing a more and more rise in fatal and non-fatal reports, including nitazines. When we'd sent samples off to Wedinos, we were having people walking in and telling us about non-fatals where they hadn't been able to press the plunger all the way down before they were completely out there and people were having to use naloxone on them. So we knew we had our original arsenal of naloxone and harm reduction advice and telling people not to use alone. But really that sparked some imagination around, like, what else could we provide to somebody to make it so that if they wanted to use substances, they could use in a safer way as possible. So in line with Welsh Government, they gave us some funding to buy a lot of nitazine testing strips. So we developed a way to use those testing strips. We then went around and trained everybody in Wales how to give out those strips so that people could use a form of drug checking in their own homes. We were very cautious at this stage because I was already looking at more advanced drug checking and the fact that we would need a Schedule 1 to be able to do any form of drug checking. So that includes these nitazine testing strips. So we can't use a nitazine testing strip in a building unless we've got our Schedule 1 license. So we're very much reliant then on giving the end user the strips, the advice, making sure they know how to use it properly so they can get an accurate reading, looking at what could lead to false positives or false negatives. It leaves a lot in the I said grey areas. So we were trying to see what we could do to develop any better. So we then looked at who can help us. We reached out in our local area to Gwent Police. We were already doing some work with BTNX in Canada around the testing strips. We reached out to the Loop, we reached out to other people that were doing drug checking. And then I came across these people here called the Trans-European Drug Information Network. And they've got like a Bible on drug checking. So it goes through every level of drug checking that you could provide, what you need to be the gold standard, how trained the staff need to be to operate different machines. It's going right the way from testing strips to like QTOF machines like Wedinos are using down in their lab. So literally lays it all out. It's an agreed framework that we can look at and give some really solid advice. I have in the slides when they come out even, there's a link in the notes that will take you to the full guidelines because it's about 40 pages long, I think. So the next big obstacle for us was to look at the Schedule 1, which is needed for drug checking. Maybe naively, I thought we've got a Schedule 2. Schedule 1 would be absolute breeze, absolutely easy to apply for the Home Office. I was completely wrong. There's a lot of information that they want. And I guess what I'm hoping for is that as more services come on board and are offering drug checking, and we show that we can do it legitimately and follow all the rules that we need to provide with the Home Office, we can then start looking at working in collaboration with people like the Loop and going back to the Home Office saying, if we could have this amendment, it would make drug checking a safer place for the people in our community. I think all in all, it took about 18 months for the application with the Home Office, including a compliance visit and a lot of photos and a lot of back and forth about wording and where we've landed. And I think we've landed in as safer place as we can at the moment with drug checking and doing it through GDAS. We are kind of okay with the wording. I think there's some that could do with some amendment, but it's things that we can look at in the future. So just want to look at, so we had our license, we did our first live test of an illicit substance on Welsh Overdose Awareness Day, which was the 16th of December, I think. So we tested on the 15th, which was the Friday. And to date, we've tested 30 samples with purchase intents of diazepam, crack cocaine, heroin, and ketamine. So most of the purchase intent have been as intended. We haven't really seen anything really radical in the test results or in the extra test results that we get from Wedinos. As part of our services that we will look at preliminary results through the FTIR and the drug testing strips, but then every sample then goes to Wedinos via Gwent Police so they can be further analysed, and then we've got more evidence as to what that substance contains. Because as you go through it in the TEDI guidelines, as you go through the different levels of drug checking, there's limitations to each level until you get to, I think the most advanced would be like a nuclear lab where you could look at actual nuclear that are in the chemicals that you're testing. So on the 16th of January, we tested a sample of what was purchased as heroin. We were able to identify the presence of nitazene, xylazine, paracetamol, and caffeine on the day. So we were able to give that person tailored harm reduction advice around what we thought that substance contained so that they were safe to use over the weekend, because this was a Friday. I guess the other complication that we have to add in is that if we look at the analogy of the sample we test is a cake, right? We are only testing that sample that's given to us, and that might be a crumb of the cake on the plate. We don't know for sure what the rest of that cake is. If you think the cake is like an ounce or 9 ounces of heroin, different parts of that ounce will contain different substances, especially when there's different cutting agents in, and they're not cut in pharmaceutically, so every portion is not exactly the same. So we were able to give that harm reduction advice. It was a lady that we talked to. She then told us that she knew at least another 6 heroin users that were buying from the same dealer. She said that she would go and speak to them all, make sure they all come in for extra naloxone kits, make sure they don't use alone over the weekend. And then on the Monday morning, we had email confirmation from Wedinos to say that the major was xylazine, and then the minor was, and I'm not going to try and pronounce them because that's not me. It's just too advanced in all these words. But you can see there's 2 nitazines there in the minor, and then the bromazolam and the nitrozalam, I probably mispronounced that. They're a form of synthetic benzodiazepines. And then they could also see the paracetamol, the caffeine, the noscapine, and the 6-mem. And I think that we've grown accustomed to being used to having paracetamol and caffeine cut into the heroin supply. So that's not really a surprise to us. So I've then put a picture up. So before every sample is tested, there is a photo took of the substance so that we can look back as reference to see what that looks like, similar to what Wedinos provide on their website. I think the ambition for GDAS is that at some stage we would have a form of website where we can show the samples and the things that we're finding and maybe links to Wedinos, but we're still in early stages of discussing that. I think the thing that stood out for me and that all the people involved in looking at this sample was that the heroin didn't really look like heroin. That picture's a bit hard to see, but it was kind of wet and clumpy, and they had wrapped in a bit of Rizla to bring in for us to test so that you can see the Rizla paper there. So I think in the background they had to do a test to make sure the Rizla wasn't coming up on the machine and everything. I've talked a bit fast because it's only 13 minutes. So I have got a last slide, and it says any other questions, but we're going to save the questions for the end. But I just wanted to show this photo. So this was on Overdose Awareness Day, just of me and my friend, that imagining this idea right at the beginning of what we might possibly be able to do. So I wanted to include a photo of him as well. Thanks.
Thank you, Gavin. I know it's been, a mission for you, but you've been dedicated to getting it through. You've overcome loads of obstacles to get that in place. So a credit to you and Gareth and all the team. And for commissioners for supporting you to move that forward. I'm sure there'll be loads of questions at the end asking you about that. But next up, Katy Porter, Chief Exec of The Loop. Over to you.
Thank you, Caroline. Thank you for inviting me to speak today. And it's really exciting to be speaking alongside another provider of drug checking services, because I think for some time now, and I know Fiona's on the call as well and in the audience here, is we've been on our own for a while in terms of the development and the delivery of drug checking services. And I think it becomes even more powerful in terms of the progress that we can make and the opportunities to progress drug checking if there are more people round the table, more voices who can provide evaluation, who can provide experience of delivering drug checking, and look at and demonstrate the opportunities that this presents for us. And as you say in the headline for this, as a routine drug checking intervention, drug harm reduction intervention, and pushing even further in terms of where this is, what it can offer, and making sure that this is provided to even more people as a routine harm reduction intervention. So I'm going to give you a bit of an overview of why we conduct drug checking and drug testing, but also really think about these last few years, couple of years, where we have been delivering the first regular drug checking service in the UK. We've been in Bristol now for 2 years, and we're moving into quite a period of significant development, not only with having GDAS go live in Wales, but also in terms of progress we're making as well in terms of standing up more drug checking services. But ultimately, the primary aim that we want to undertake is this is a harm reduction service. And the value of drug checking as we see it is that we can directly make contact with people who are taking drugs, whether that is occasional drug use, whether it's dependent, non-dependent drug use, and I'll come on to some of the policy areas around this. But from our point of view, we see this as a universal intervention which can have value to all people who use drugs, in whatever that drug and whatever the frequency as well. And that's really been the development of the organisation over the last 12 to 13 years, is really thinking about that broad offer that drug checking can have in regard to reducing harms and potential for reducing drug-related deaths as well. We monitor the drug market for change and trends, and we don't work in isolation. That's the important aspect around this as well. It's always working in partnership, whether that is in a festival environment, whether it's in city centres, communities. As Gavin had said in his presentation, who do you need to be speaking to? Who do we need to be speaking to in order to be able to deliver services effectively so that they have good reach, engagement, but also importantly that they work within the appropriate frameworks, and we're able to engage people who need and want to access this service as well. And we know from the research that has been done previously with the Loop, we are reaching people who maybe aren't in contact with services, possibly don't need to be in contact with traditional treatment services. This is about early intervention, this is about prevention, and ensuring that people have access to good, accurate information, which hopefully means that no, they're never going to need to come into the type of drug treatment services and system that we have across the UK. So we've operated a mobile lab approach facility now for many, many years, and that enables us to be in different places, albeit for short stints of time. And I think this is one aspect why our partnership is so important, is that actually we will be operating in different areas around the country. And what we want to ensure is that intelligence, that information that we generate in that area can have value across a broad range. And as we leave, other people pick up that information, that knowledge, whether it's peer-to-peer or whether it's across different people working in different types of services, that can then be built upon and shared with others. We operate, as Gavin touched upon, the type of testing that is needed. I know we've got one of our chemists, Sam, on the call as well. So we have technical experience in the room as well, and we will be operating with FTIR in order, similar to the Shimadzu that Gavin noted on his presentation, and infrared spectroscopy being our first line of analysis, but combining that with other analytical techniques as well. And it's right that synthetic opioids do present a challenge for us. They are there in small quantities, can be difficult to detect, and the immunoassay strips are an absolute necessity in terms of the lab and how we operate, and are highly effective when used in an accurate way. And that's where there can be challenges in terms of usage if not used in a particular form and dilution, and that's where we can get some pushback regarding the accuracies and false positives around that particular use of a testing opportunity. But importantly, drug checking is always combined with direct contact with an individual. It is receiving submissions from an individual, and importantly, that gives us the opportunity to understand what someone thinks that they have purchased, what they are intending to use, and that assists us all in terms of understanding the drug market, and in a way that we just don't get when we're operating with confiscations and drug testing and back of house. Whilst that still has value, we want to ensure that we have as much opportunity to offer drug checking to individuals as we possibly can. And that enables us then to tailor that conversation, that intervention with the person who has submitted the substance, and have that conversation post that test result. And we in reaching across communities, we can see the different substances which are coming into the market. We can monitor drug trends, and then we can look at that alongside partners, and also in the context of some of our back of house testing as well. Importantly, it's real-time information, and this is where the value of both drug checking and drug testing when it's on site can give that immediate and real opportunity in the way that Gavin described around that case study on a Friday afternoon, and that having real-time rollout of that information to a community of people who could benefit from that information. I provided this slide because also there's a link on there that actually, if you click that, you will have opportunity to see a video of the mobilisation of our drug checking service in Bristol. I mentioned that at the start. It has now been running for 2 years, and the video that you'll see on our website was taken on the first day that we went live. Fiona, myself and other colleagues in the organisation, you'll find us on there talking about drug checking, what it offers, and have an opportunity to see that in action. I think I've covered sort of the key aspects there, which are captured on that slide, and really the main aspects of drug checking as we provide them. So to touch upon the operating environment, and Gavin, you've spoken about the wait that you had for getting the Home Office licence. You're the first one that you've received on that. I'd like to say to you that it gets easier, but it does a little in terms of familiarity, but it continues to be a very detailed process, and one which, yes, from an administrative aspect is significant. It's very thorough, and can be seen as a lot of hoops to jump through, I suppose. It is a possession for controlled drug license, for controlled drugs that we hold, but also increasingly we have to have other aspects of criteria within our legislation, because just as Gavin had talked about substances going to Wedanos, that also comes under supply, and we have that in relation to our services, that we will have our mobile lab, but we will also have a relationship with a fixed site lab, so that where there is further rapid analysis that needs to take place, that is within the framework of our license, that we're able to have that onward testing and have that partnership around the further analysis that may be required. So yes, the Home Office license has to be in place, and another key aspect of that is they are site specific. So for us, in operating across different parts of the UK, every time we are in a different location, that requires a different license, an additional license. So we're getting quite a number, and again, I'll show you a slide which demonstrates where we're at in terms of that. I also have put on there and noted another piece of legislation as well, which is having an impact for us as well. And this is the Online Safety Act. So one of the key aspects around our work is, yes, our direct contact with people who are using the service, but also the value of reaching out to wider communities, reaching a greater number of individuals, and doing that significantly through social media. And similarly to what Gavin has described, we take images, really high spec images of the substances that we have tested, and very much have ensured that those are going out on social media when we are creating alerts, and the importance of those images in terms of being able to see what they have purchased, what they're intending to take, alongside the information around that is absolutely key. And some of that is presenting challenges for us when those images are going up and there is messaging regarding drugs. This is being seen as being in breach of community guidelines, and our posts have been taken down. And so we need to think about the different challenges that we have, not only in thinking about licensing and the legal framework around that, but also how do other areas of legislation impact on harm reduction as well, and getting effective information out to people when needed. So I am going to give a little bit more information regarding the policy area here as well, because this is critical to the licence and the way in which we operate. So it is extremely positive that we are now able to operate and stand up drug checking services. We aren't quite there yet in terms of the universal offer of this. We have to operate within current drug policy, and UK government policy deems that drug checking is to be targeted towards dependent users, and we've been operating with that policy since we commenced in Bristol, and under both Conservative and now Labour government as well. And for us, it's continuing to have that dialogue with the Home Office regarding how can this be applied in practice, what's the best possible way in which we can build this into our services and remain compliant to legislation, but also raising some of the challenges that this does present for us as well. So there is an area where we, in terms of talking about dependency, how is that defined? And how do we look at that in terms of treatment that might be provided, patterns of use, behaviours of an individual, all of those various things which could be considered to be areas of consideration in terms of assessing dependency. And again, I'll come on to that a little bit more. But there are also some additional criteria that we need to have when delivering our services. They need to be aimed at over 18s. They are to be based in a treatment, harm reduction or healthcare setting, and results are to be embedded in a consultation. That one has no issue for us. That is always has been our approach. And then additionally, they need to contribute to local and national early warning systems. And in our provision within Bristol, and as we develop, these are all ways in which we have to deliver the service, publicise the service, make sure that people coming through the door to receive the service are aware of how we're able to offer that service. That said, we are able to take in substances of any type into the service if an individual wishes to have that tested, possibly not demonstrating dependency. We are able to test that, and we are also able to provide a harm reduction consultation, but we may have some limitations in terms of the information that we can directly provide. So in terms of just where we're at as an organisation, and I'll come back to touching upon sort of where we're going with that dependency criteria, because we have got some progress and development in regard to that as well. But under our existing service delivery, and over the last 2 years and operating in Bristol, we've delivered 56 days of testing and checking. It's possibly runs a little differently to how GDAS will be operating, that these are pop-up services really, and we will have focused and more sort of intensive service delivery where people are there's publicising of that service happening in a particular area, and encouragement from our local partners, local stakeholders, trusted individuals in that local area to encourage people and talk to people about the service being offered. And in Bristol, we've had 24 days now of public facing drug checking. It continues to be commissioned by Bristol City Council, and we're going into further year of commissioned service this year, and very much supported as well by Avon and Somerset Police. They have been a key partner of us, and that is formalised through the Combating Drug Partnership in the area, where that is co-led by Director of Public Health and the lead for drugs within Avon and Somerset Police. And alongside that, we've operated 32 days of back of house testing in venues and festivals. We have festivals that we're regularly at, but we also are regularly at 2 large venues, one in London, one in Manchester, at different points in the year. And as I said, that helps us in terms of that broader understanding and contextualising of the drug market. And so when we are seeing substances come through into our drug checking service, we're able really to look at that and test result alongside a broader context that we have and data set that we have regarding the drug market. Specifically to drug checking, we probably see a broader range come through into our drug checking service. 30 different types of substances over the course of our couple of years in Bristol, whereas typically within a festival or club environment, we might see a more limited range of substances, as you might anticipate. And the top substances that we're seeing within our drug checking service: benzodiazepines, ketamine, heroin, followed by cocaine and MDMA. Also importantly to say, we have had nitazenes tested, submitted within that, and that has both been as a substance that someone's purchase intent. They submitted it to us, saying that, you know, I believe this to be a nitazene, and I want to understand more about the type of nitazene and the related harm reduction messaging. But also we've had oxycodone pills which weren't the person purchasing those hadn't intended to be taking or purchasing nitazenes, and it was in the content of that pill. But I note that because I think we need also to consider that this isn't always about finding adulterants or seeing this as an adulterant. Sometimes nitazenes may be something that someone is seeking out, and we need to be prepared for that as well in terms of treatment, harm reduction messaging that needs to be associated with that. And I think also importantly to say that also it is just as important, we are finding that actually some of the biggest risks in the drug market is the strength of the substances that people are intending to take as well. So again, it's not a risk from a contaminant or an adulterant, as people might describe them. It's also the substance itself as well, the purchase intent. Also note within that our drug checking always has alongside it the additional harm reduction support and intervention as well, and notably naloxone as available to people, and the provision of that to anyone who uses the service. And that won't just be restricted to people who have presented with a type of opiate. It will be talking to anyone and everyone who comes through the door regarding what naloxone is, what the value can be in terms of understanding or its usage, carrying naloxone, whether it's to keep yourself safe or whether it's to keep others safe as well. So where are we at in terms of development? We now hold 6 Home Office licenses, with 3 currently pending to stand up additional services, and those 3 are all additional drug checking services. The other 5 Home Office licenses we have are for back of house testing, and it is the case that currently there is we can gain licenses for festival and club environments. We're not able to gain those currently for a drug checking service within those environments. So we are very much focused on working with cities, with standing up drug checking within those community environments that can work with people across all types of drug taking, drug use as well. So we will be mobilising. We will be launching in London shortly. We will be making key announcements. So you've heard that, but please, wait for us to make those very much those sort of media press announcements shortly. It will be going live soon. But we are talking to other areas around the UK as well, and we very much anticipate that there will be more than 2 cities in England that will be delivering drug checking by the end of this year. And as I've said, it's really exciting that we have now the development that it is in Wales, and also the developments in Scotland as well happening. And I think, what we want to see is how can we as providers be coming together as well to be sharing good practice that we are seeing, that we're able to put in place, but also what are our challenges as well, and how can we collectively feed those back to whether it's Home Office, whether it's OHID, whether it's commissioners, whoever that might be, to raise some of the benefits, but also why there are maybe some restrictions in terms of how we can actualise those benefits currently. So coming together in terms of networks, not only to share the experience of delivering drug checking, but also thinking about the information that we're gaining from that and how can that be best disseminated. And I think importantly, what we are seeing is that we are able to revisit that aspect of how do we define dependency. And importantly for us, we feel as though we're going to be able to cast the net a bit more broadly as we go into our drug checking for 2026 and working with people who are in mild to moderate and severe aspects around dependency and reach even further in regard to this. I'll stop there. I think I've taken up plenty of time, but hopefully now leaving sufficient time for questions as well. Thank you.
Oh, thank you, Katy. That's really interesting and quite exciting. I think on the last times I saw you, it was all sort of a bit depressing on the front, and now it was all a bit, everything was very challenging. But that sounds really promising, and I think, as you rightly say, getting networks and providers working together to overcome any challenges, share experiences, share knowledge, it can only be a good thing for people who use drugs. So Lucy, there you are, Lucy.
Hi.
Questions for our speakers.
So Gavin, if I could just start with you, we've got a few questions about some of the details of what you talked about. So you mentioned about the nitazene or nitazene, I don't really know which way to pronounce it, the test strips.
We all know what it means.
What was the take up of those test strips like in your service? Was it just opiate users, or were others taking them even though they didn't kind of class themselves as opiate users?
I think the take-up was pretty good across Wales. I think we gave out between 5,000 and 6,000 testing strips, not only to opiate users, but also the people that are using tablets or anything, in fact, that they wanted to test with them. That I guess the limitations are though, that we were giving it to an end user to go and do in the living room. So they might have not had the right equipment, they might have not used the right measurements, and the testing strips vary on the reliability down to all the things that I've just discussed. So obviously in a lab setting, you've got much more control over it. But we were, because we were already in the process of looking at the Schedule 1, we were very adamant that they could not be used by staff in the staff building, because it would have put the whole license in at jeopardy.
Yeah, absolutely. And was there feedback from service users about the test strips once they'd used them, in terms of what they found once they'd used them, if they'd used them, assuming they'd used them properly? Was there much kind of give and take in terms of that conversation afterwards? We had good feedback in Gwent particularly. I mean, we were having people that would test, it would show a positive in the house, and then they would bring a sample in first to test with Weddinos.
But I guess that's where we started to see some of the false positives then. So, because Wedinos was saying there was nothing in there, but on the picture you could clearly see that it showed as a positive. But obviously the testing strips on a different generation now as well, and the generation before the caffeine was affecting it. And like I said on the case study that I gave, we're used to seeing caffeine in the heroin supply. So if that's going to cause a false positive, it's an issue for us. But we've been working with One Use and BTNX to try and feed that information back, and they're happy to do some research with people as we move forward.
Brilliant, fab. Thanks, Gavin. Katy, I've got a question for you. In terms of the information you provided about samples you were testing, it says it's from Josh Torrance. How many of these samples were tested at the drug checking clinic in Bristol?
I saw that question, and I don't have the absolute figure off the top of my head. However, what I would say is that it's a smaller number currently that will come through drug checking. I think we need to think about it in terms of it being quite a different offer in terms of providing drug checking in a local area. And what I think a lot of our learning has been is actually, how do you facilitate access? How do you make sure that people, and it was on my last slide, how do you build trust as well? In the past, when we provided drug checking within festivals, people have come in very large numbers. It's a much more anonymized environment for people, and I think it's one of the things that has been a learning for us in terms of how do we make sure that we can facilitate access in the best possible way. What I would say is that we also have criteria where people can bring more than one substance into us as well, recognizing that actually if people are coming and using the service, we want to make sure that we can facilitate testing for more than one substance. You know, we want to reach people, and often we are finding through all of our work that people are not just using one substance, they will be using more than one. So people can bring in more than one substance at the time. I think, again, some of the aspects regarding how we've been working in terms of trying to define dependency, we've needed to make sure that we are really tight on our compliance around that, and that has maybe held us back a little in terms of kind of opening this up more broadly. We are feeling as though we can move into a phase where we will be able to offer drug checking to, as I said, casting the net a little bit more broadly. So in answer to your question, Josh, I can get that number, but I also anticipate it will be a lot more within our samples as we go forward and into this year.
But I was going to say, can I just add a little bit there? I think that, like what Katy is talking about is really important. It's about that trust and knowing it's confidential. Obviously, we've got the restrictions or the limitations from the Home Office. You have to comply with them, but that trust is massive. And we were fortunate in GDAS, I think, last year, because essentially we've been doing drug checking, but not on site for years, because Dean came from a Gwent service. So we've always had a massive relationship with Wedinos. I think last year GDAS sent like 220 samples to Wedinos. So people already know that they can trust us, and that we're not going to, from the police, and say, John's brought this sample in, it's got this in it, or it's got that in it, because we've essentially been doing it without having a lab on site for the years previous. So it's about building up that trust level where you're working.
Thank you. It kind of quite nicely leads into the question, actually, because you talk quite a lot about both the importance of kind of compliance and being able to kind of abide by the Home Office kind of rules. And one of the questions, Gavin, was for you. Is like, what was needed by the Home Office? What did they need from GDAS to be in compliance? And Katy, I know if there's anything as well you can bring in, but for Gavin particularly, what was that experience? What did they need from you to actually get this license?
I think it's just trust the other way. So the Home Office want to know that you are going to safely handle those substances. I mean, we're talking about serious substances. Yeah, I mean, we could have fentanyl brought in, which is like a chemical warfare agent. Like there's substances that they need a lot of control around them. So we have to be careful. I think that I naively thought that because we had the Schedule 2 for giving out methadone and buprenorphine and everything, and the applications for that for Kaleidoscope are fairly painless now because we've been applying for 20 years. So we know what we need to write so we can get everything ahead before the application goes in. I think that some of the learning for us is the things that the Home Office came back to on the original application, where they asked for extra advice, extra stuff around the evaluation methodology, and we didn't quite lean on some of our university partners as much as we should have in the beginning. But it was a learning curve. Like we'd never applied for that license before. I think that the license would still take a long time if we applied for another building, but obviously now we've learned what we need to put in that application about the partners with the universities. On this slide where I said who can help, I didn't put any of the university pictures on there because there's some stuff going through like ethics in some of the Welsh universities and stuff at the minute, but they are very much a key partner. They can help you with a lot of the information, help you with all the evaluation. They've got staff that know exactly what you need to write in there. Everything else is fairly similar to having methadone in the building. It's about where it's going to be stored, about who's going to come and collect it at the end of the day and what's going to happen with it. They wanted to know about how we were going to dispose of all the samples. And we don't technically dispose of any of the samples. The police take it straight to Wedinoff, so then they test and dispose of everything. We don't keep anything on site. But all the things like that we could have added in the beginning. And it might have still took a long process for the application to come, but I don't think they would have come back so many times.
Wow, brilliant, thank you. So a few more questions. One for you, Katy. So you made a comment about the Online Safety Act and the kind of posts that had to be pulled. So what was their reason for needing those posts pulled? And is this something all drug services need to be aware of when it comes to social media?
I would encourage anyone to, if using social media, to look at community guidelines and consider how you need to remain within those. I think one of the challenges that we've got is often you don't always get to understand why something has been pulled, because now speaking directly to someone to seek advice and say, could you explain to us a little further regarding how that has been seen to be in breach, that is very difficult to now get that direct contact. And I think it's worth considering that a lot of the time when decisions are being made about pulling a post by Meta, by different social media platforms, it isn't necessarily completed by a person themselves. There is a lot of use of AI which will screen, and that has real value in terms of some of the screening in terms of content across the internet. And there are things which absolutely it's very helpful that it is non-human screening that takes place in terms of moderating content. But it can mean that some of the very important information that we will all be generating and putting out in this way is pulled, and then trying to have that conversation about, no, we are a harm reduction organisation, this is for the purpose. So certainly just a post saying around drug checking was pulled at one point in Bristol because it was seen that we were promoting people being able to have drugs checked and then be so it's that understanding and nuance which is so difficult. So I think we're in a learning stage of the sophistication of some of the application of the Online Safety Act, which I think we're certainly in a stage where we're having to think about this very carefully in terms of how we word our messaging and the images that go with that as well.
Thank you. Just to stay with you a moment, Katy. So we've got a question here. Have you noticed any changes in societal or political attitudes towards drug checking and testing since you started versus now?
You might want to, Fiona might want to come in on this as well, because Fiona's been in this from the very start. But I think it's fair to say that actually, from a societal point of view, and then looking at our fairly, our significant media and press content that has gone out on this, it is very rare that there is negative pushback. I don't think we've ever had, kind of that public pushback on is this not a sensible thing to be doing? And I think that's what we try to emphasize when we are having conversations with policymakers where we are seeking to influence that political position, is actually our experience in terms of going out to public regarding drug checking, its purpose, its value. We've always had very positive response to that. And campaigns such as and working closely with Anyone's Child and the positive work that they do in terms of calling for drug checking to be available is really helpful. But I think also importantly in this, we don't want to be a lone voice, and we recognise we're not a lone voice. But the more that we have GDAS, Scottish colleagues, yourselves calling for this to be something which is routine, is very helpful. And I think that's our hope as we go into this year, that also as further commissioners, public health come on board with this, that actually then we can start to tip that in our favour even more.
Fabulous.
I can see it. I said Fiona might want to come in.
Yes.
So that would be.
Yeah, I totally agreed with everything Katie said. The only thing I was going to add, just as a way of an observation really, was back in the very, very early days when I first cooked up the idea to try and introduce drug checking. One of the things that's interesting is that nobody was really calling for it. So, drug services weren't really calling for it, but also drug policy reform groups weren't calling for it. And one of the things that I was told regularly was, this is impossible in the UK without a change in the law. You're going to have legislative change. And I didn't think that was the case, but I'm really pleased to see that it's spreading across the UK without legislative change. And there's only one country in the world which had that, which is New Zealand. So, I think it's just worth noting that, sometimes we think we have to go through Parliament for things, but actually not necessarily. You can go down the boring bureaucratic route, which can be painfully slow, as we've all experienced, but it is possible, and it doesn't necessarily have to go down the sort of party political route as well. And I think that's just what, it's just something worth noting really, is that we haven't had a change in the law to get this off the ground. What we've done is peck the heads of the Home Office for 14 years to get it off the ground. And I'm not saying one or other's better, but it's just something to note that we haven't gone through Parliament for this. And we do, I think, there's fantastic support for it, in the country, amongst the general public. As Katie said, we've not had any negative press really. But I did want to mention something about the tides, the winds of change going the other direction. And this relates to the Loop Australia, is that they had a fully funded service by Queensland state government, and we're really excited, very, very well funded. And then they had a change of government from Labour to the Liberals, which are their Conservative Party. And after only a year, the whole service and all the funding was pulled and it had to close down. But the other thing there is to mention about this and Parliament is the Liberal government there very quickly passed legislation banning drug checking. And I just raise this as a word of caution, because this is, 2026 is a year of celebration. It's fantastic, that we're going to have drug checking services in England, Scotland, Wales. I couldn't be happier. But, we are in strange times politically. This didn't go through Parliament, and we just need to keep an eye over our shoulder about what's happening. And so that's just like my little caveat there. Having seen what happened in Queensland, they passed that legislation as an amendment to the health bill on a Friday afternoon at about 4:30, and they zoomed it through Parliament. So we've just got to still be a little bit nifty on our feet. That's my thinking in terms of the policy landscape.
Yeah, thanks Katie and Gavin, and thanks Fiona for adding that. Lovely to see you again. let's do hope that we continue this more and more of this being routine and commonplace. It just makes sense, and we've just got to keep on the benefits of it. So let's all work together on that. Thank you to the team to put these webinars together. You make my job look really easy. And then look out for our next one, which is on the 17th of February. I hope I've got that right. And that's around enhanced harm reduction centres. Another thing that should be part and parcel of our harm reduction interventions, and checking and harm reduction centres together even. Wouldn't that be something interesting? So anyway, just thank you very much. Thank you for coming along, and see you at the next one.
If you have been affected by any of the issues discussed in today's podcast, please reach out. Barod have a free and confidential live web chat service that is available 7 days a week on our website at barod.cymru, where you can chat to a trained support worker. Alternatively, you can contact Wales's National Drug and Alcohol Helpline, Dan 24/7, either by calling 0808 808 2234 or text Dan to 81066.